I actually did not believe people would respond to my suggestion. I'll get a copy of the comments.
Well, there you go. Go get it.
It's the power of this podium. It must be the case. I'm going to go ahead and introduce myself. My name is Stuart Little, and I am the lobbyist for Oral Health Kansas, and I'm going to be introducing our two speakers today on this plenary session on prevention through Medicaid reform and the implementation of CanCare. This is the final session about CanCare today, and the first speaker is Scott Bruner. Scott directs the Kansas Health Institute's work on Medicaid insurance coverage and access to health care. Before joining KHI, Scott had several leadership positions during his nearly 14 years as a Kansas government employee. Most recently, he helped oversee the transition of the Kansas Health Policy Authority from a freestanding agency to a division within the Kansas Department of Health and Environment. Prior to the merger, Scott served as KHPA's Chief Financial Officer. He directed the state's Medicaid program from 2004 to 2006. Before and after primary responsibility for its management was transferred to KHPA from SRS. Scott holds a master's degree in American Government and Public Policy from the University of Nebraska at Lincoln.
Thank you for that introduction. I can summarize it in a sentence. And I worked with the Medicaid program on the state side for much of the last decade, and so that's where my background is, and kind of my passion is for the Medicaid program as it serves very vulnerable and frail Kansans and other people across the country. It's a tremendously important program. So I'm happy to continue working for the program and with the program in my role at the Kansas Health Institute. And I'm going to talk to you today a little bit about the CanCare proposal that's being considered now and moving through the CMS approval process, and try to talk a little bit about kind of what managed care is, to make sure that there's a good understanding of the mechanism of managed care and how it would work in Kansas. Talk a little bit about the process for approval of the plan through CMS, and talk a little bit about the contractors that have been awarded, the companies that have been awarded contracts to operate the program, and give you just a couple of highlights about them. But before I jump in, just let me talk for a second about the Kansas Health Institute. KHI is a not-for-profit, nonpartisan research organization based in Topeka, Kansas. We do work primarily on state health policy, but we cover a variety of issues. You had one of my colleagues here yesterday, Suzanne Trent, who directs our work on health reform, the Affordable Care Act. We've also got a large body of work in the public health arena and in community health improvement, and so we have a broad reach, but generally we cover issues of health and health policy. Our primary funder is the Kansas Health Foundation, based here in Wichita, and we appreciate their ongoing support for the work that we do. And the last comment, just as a way to, I guess, a plug, and I reference it in the slides, but our website, khi.org, is a really good place to go to find information. Suzanne probably pitched it yesterday too, to find out information about policy details and things like that. That's the work that we do. But I'd particularly point you to our news service, which is staffed by some of the leading journalists in the state, long history of working and covering state policy and politics, and that is a great place for daily updates on things that are really pressing. It's not all CanCare, not all Affordable Care Act, not always dental issues, but really the pressing issues of the day, and very good comprehensive coverage of those issues. And if I forget, I'll try to mention the website again at the end of my talk, because I keep trying to add it to a slide and I keep forgetting to put the website on there in detail. But so that's my intro. So let me just talk a couple of minutes about managed care and what that is. It's a terrible academic thing to do, but you shouldn't define something by what it's not. But this is the simplest way I've come up with to try to describe what managed care is. And it's not fee-for-service. Fee-for-service, if you work in a dental practice or medical office, is the way that health insurance has worked for since the 40s, when health insurance was came into wide operation. But in Medicaid world, I try to talk about it in terms of Medicaid. In the fee-for-service fee-for-service world of Medicaid, if you've got a Medicaid beneficiary, somebody who's eligible because they have low income, or they're a pregnant woman with low income, they're over the age of 65 and low income, or as a person with a disability, they go to a provider and seek some kind of a healthcare service. It could be a dental service, depending on eligibility, or hospital, or physician. And the healthcare provider has an agreement with the state that says they'll provide services to Medicaid beneficiaries at an agreed-upon rate or price, and for an agreed-upon amount, duration, and scope. So how many units they can receive, how many visits they can receive, and under within those parameters of the agreement, they deliver the service to the Medicaid beneficiary, and then the provider bills the state, and expect to get a payment back from the state for that service that they provided. That's fee-for-service. Under managed care, what's different is there's an intermediary in the relationship between the state as a payer for health services and the provider as the deliverer of health services. And that's called a managed care organization, or an MCO. And in managed care, the state leases networks from MCOs. The health plan, or the MCO, negotiates rates and terms of service with providers, and then the health plan actually pays the provider for the services that are delivered. So it's the payment mechanism, for those of you that work in dental practices or provider offices, that mechanism and billing process isn't very different. What's really different is that an intermediary between the state as the administrator of the Medicaid program and the people who receive Medicaid benefits, there's a third party or managed care organization in between that relationship. There are some other things that get added. Providers have to meet the coverage, access standards, case management requirement, treatment guidelines from the health plans. So there's where the provider agreements now are based on state guidelines. Those are a little different, could be different with the MCOs. And also then the state's job really is to enforce contractual requirements with the health plans, and I listed a few of them there on the slide, that are really about how the network operates, how the system's supposed to function, and what kind of outcomes people who are in Medicaid should see. So that's what managed care is. And the proposal that's working forward now is not based on this slide, but let me talk about this slide. So what I thought, and sometimes when I do this talk, people don't have a lot of background with managed care. I think it's an entirely new idea. It's not in Medicaid either. What this slide shows is the penetration of Medicaid managed care across the nation. And it uses a term of art in the health research world called comprehensive managed care. And that's important because it means most of the services that people receive, physical, behavioral, home health services, things like that, are all provided through managed care. So this is the closest correlate to what CanCare would propose. And what you can see is that there are the blue states the lighter blue color states are ones that have a greater proportion of their Medicaid beneficiaries in managed care, between 76 and 100%. You can see that, and we're in a group of states that are orange, and that's between 0 and 54%, and our rate in Kansas is 49%. So right now, half of our Medicaid population is currently enrolled in comprehensive managed care.
And that's before CanCare, right now, today.
This would have been in 2010.
Okay, so not discussing after January 1
No,
of 20.
after January 1, it'll be significantly different than that. Maybe I should watch the slides instead of read through my notes, because apparently I'm working off an old list. But so that's what that is. So it's not new, and lots of states do managed care and Medicaid, so that's not a new idea. But let's talk about what's new in Kansas, which I think is what the next slide is. Oh yeah, good. So with CanCare, everybody who's eligible for Medicaid, the change, the innovation that's being proposed is that everybody who's in Medicaid would be eligible for CanCare and moved into comprehensive managed care organizations. That includes infants and children, pregnant women, low-income adults, and persons with disabilities. The dual eligibles, so people who have both, who are age eligible or disability eligible for Medicare, but also have Medicaid because they're low income, foster kids and special needs kids, they're going to get added into CanCare through the waiver process that's ongoing. But the basic idea is that everybody, 380,000 people in any given month that are eligible for Medicaid in Kansas, are all going to be served through CanCare starting in January. So this is to Kevin's point, it's sort of the first attempt to describe what the shift is with CanCare. The bar on the left-hand side shows the Medicaid population in the state, and the green area are kids and families, the red area are people with disabilities, and the blue are people over the age of 65. And then those same colors translate to the right-hand column, which is where the money goes, total spending. So, not to dwell on the numbers very much, but one of the things about Medicaid, and this is true across the country, is that most of the people in Medicaid that are eligible are children and families. But they make up roughly a third, or about 25% in Kansas, of the total Medicaid spending. Most of the money that's spent in Medicaid goes to people who are disabled or the people who are over 65. And so after January 1, and right now, you can go to the next slide, this probably tells the story a little better. So after January 1, that money's going to shift. So now the blue column, or the column on the left, I'm sorry, is still people, and the column on the right is money. And so the blue area represents people who are, according to CMS in 2010, enrolled in managed care in Kansas Medicaid. And that's about 85% of all Medicaid eligible beneficiaries are in managed care in Kansas. The part that are in comprehensive managed care, where all of their services are essentially managed through an MCO, is where that line is that I drew at 163,000 people. So about half of the Medicaid population is currently served through a managed care type plan. But in terms of dollars, the blue area in the right-hand column represents how much money is spent last year, in fiscal year 2012, on managed care services in the state. And that's $697 million, $2.1 billion out of the total 3.2 or whatever that adds up to. So about 75% of all the money that's spent in Medicaid is spent through a fee-for-service model, primarily on services for people who are disabled or over the age of 65. The managed care spending in Kansas is only about 25%. On January 1, the bar on the left would be all blue, and the bar on the right will be all blue. So it's a significant shift of the Medicaid population into a new service delivery model, and a shift of a huge part of the money that's spent providing Medicaid services. So it's a big change. I could have just said that from the get-go. But so on the next slide, on January 1, according to the proposal, all Medicaid beneficiaries would be assigned to one of three managed care companies. The assignment process gives a third of the Medicaid population to each of the three contractors based on a distribution of age and health needs and where they live. And then there's a 45-day choice period. So once a person's assigned, they have 45 days to choose to not stay with the plan they were originally assigned to. That's the only election they can make in a 12-month period. So once that 45 days is exhausted, so that's the first part of March, the Medicaid beneficiary can't change plans without a very good cause or an appeal to the state. There is a process for that. But the idea is that you've got 45 days to choose. Once you've made a selection, you're locked in for a year. And then every year there'll be an open enrollment period where you could choose or make another change. But the idea is to keep people with one plan for most of a 12-month period.
How long is that period? After the year, then what's the window they can change?
45 days. There'll be an open enrollment period. I don't think the state's talked about it. It'd probably be in October, November you'd elect, a lot the same way that Medicare works, that before the new calendar year starts, you have to make an election between October, November, December, or something like that. But it would start on January 1.
So it's not really a year?
It's a little shorter than it. Once it's fully implemented, and after this first choice period, you really have about, if you took all 45 days, it'd be 8.5 months.
It's really, if you say that,
9.5
if
months.
they're locked in for a year, they would have actually missed that period to change.
Yes, yes. The first year is going to be a little different. The choice packets are going to go out based on the last schedule I saw at the end of October, first week in November. The 45 days doesn't start ticking until January 1st. So the first choice period for this first year is going to be more than 60 days, but less than 90. After this first year, the choice period will be mid-November, first part of November through the end of December, with effective date for coverage of January 1st. What services are covered by CanCare? This has not changed since the proposal was initially announced last November. It's all medically necessary services. So everything that's covered under Medicaid today would continue to be covered by the MCOs. And it has to be according to the contract in the same amount, duration, and scope as what's currently covered in Medicaid. And what that means is that if there's a unit limitation or a unit guideline in Medicaid today, the MCOs have to abide by that same unit service criteria, a number of visit, that same guideline has to apply. And the rates can be no less than 100% of the current Medicaid rate for in-network providers. So that's a guarantee that for Medicaid providers today, enrolling with any one or all three of the managed care companies, you get the same rate for the same service that you provide today to potentially the same Medicaid beneficiaries, but then there's assignment and choice periods from there. So the next slide. There are some additional services that that the MCOs are providing according to the contract, and I'll just do this kind of quickly. They have to provide health homes. The model or the plan is based on a primary care case management model or a primary care medical home model, and MCOs have to provide health homes, a designated place that's a home for care to certain particular Medicaid beneficiaries who have either a chronic condition, mental illness, or risk factors for several different chronic conditions. And I list that on the slide. We could talk more about that if you have questions. There are also some guarantees in the contract about existing service systems for people with developmental disabilities or people with mental health, and if you have a question about that, I can go into more detail there. But the main idea is that the services are supposed to be exactly the same. The payment rates to in-network providers with the MCOs are supposed to be exactly the same as they are today. So just a little bit about who the three companies that were awarded contracts. They're Amerigroup, and I just list these alphabetically. Amerigroup, Centene, or it's operating in Kansas as the Sunflower Health Plan, and then United Healthcare. And we had done a news story a few weeks ago, and I'm working on putting this into a research fact something sheet, I think we call them, that has these maps. But just to give you an idea of the states where these MCOs are operating today, in a Medicaid world, which is the dark blue states, or in a Medicare world where they offer Medicare Advantage, which is the managed care option for the Medicare population. And you can see that there, United Healthcare is based in Minnesota. And that map's correct. The next one is for Centene or Sunflower Health Plan. It's based in St. Louis. And since we did this map, they've added Arkansas as a Medicaid state, so you can mentally add that in, or if you print it out in the hallway, if you'd color that in, I'd appreciate it. And it'll be right in the publication that's going to come out in the next couple of weeks. And then the last one's Amerigroup, and it's based out of Virginia Beach, Virginia. And since this map was done, they've added Washington State. Maybe it's a geography test. Everybody know where Washington State is. It's up here in the corner. And of course, they've all added Kansas since these maps were done, but that's what Amerigroup looks like, or where they provide services. And this graph is very small, and I don't really expect you to be able to read it from the slide. But one of the things that I wanted to highlight and get out to people so that you can think about it is the contract said the MCOs had to provide and keep delivering all of the existing Medicaid services, but they had the option of providing some additional value-added services. And so I tried to capture on this table some of the value-added services that the managed care companies have offered through the bid process and negotiation. And I'll just highlight a couple of them, and then you can print it out in the hallway. But all three of the companies do some kind of an incentive account or incentive program for beneficiaries that meet certain health targets or attend their appointments in a timely way. And they give that incentive through prepaid debit cards or some kind of a a prepaid MasterCard or Visa card type account as a way to give money to people as a financial incentive for meeting health outcomes and doing things that promote their health, that then the beneficiary can use to purchase health services or buy services that Medicaid doesn't pay for, or if they have any cost sharing, which isn't really the case in Medicaid, but they could use the debit cards for that. They also, all three, I think United does as well, some kind of they give out cell phones to their members as a way with prepaid minutes on the phone, and that gives them, gives the MCO a contact to that Medicaid beneficiary in their hand to send them text messages reminding them that they've got an appointment coming up or that they're due for a screening or other ways of reaching out and getting information about their health care to the Medicaid beneficiary. They all do incentive programs for weight loss and chronic condition management, managing your blood sugar or high blood pressure. And then at the bottom, there were a couple of things that were added specific to, would be interesting to you, I think. One is, well, maybe this one wouldn't be, but one is that they all three companies added as part of the contract negotiations an adult preventive dental benefit to their plans. Some of them had offered this in their RFP, but by the time the final contract was written, they had all agreed, and the state had agreed as well that they would all provide an adult preventive dental benefit, which you know that was something that Medicaid has talked about for a while, that many of you that advocate for the service have talked about for years, and we've had in a limited way, and then was reduced because of budget cuts. But so that's a new thing and a very great idea, promising practice for the future. The other is bariatric surgery. The state required all three MCOs to cover bariatric surgery for Medicaid beneficiaries, which is new. And also, I didn't put on there, I don't think, transplants, heart and lung transplants, which Medicaid didn't cover for adults. So there are a lot of new services. I think there's another slide, a couple other slides. The MCOs do subcontract to provide certain specialty services, which dental would be one, and Amerigroup and United both contract with Scion to do their dental network development, and Centene, Sunflower uses a company called DentaQuest. And there are some specific things about the adult. The requirement was to do a preventative adult benefit, or the value-added service that they all added was adult preventative. There are some differences in how that's being operationalized, and I included that thanks to Oral Health Kansas to tell me what it was, so I added it to the slide. So that's what the benefit will look like come January 1. The other part that I want to add to the discussion, or just to your thought process, is the approval process, or where does the plan, it's been discussed since last October, November. There have been a variety of submissions to the federal government for approval. I want to talk just a little bit about that process. What the state's doing to get CanCare in place is something called an 1115 waiver. And a waiver is a mechanism in the federal law that allows the federal government, the Centers for Medicare and Medicaid Services, to waive for a state certain provisions of the Social Security Act and requirements under the Medicaid law. And so it's a way of saying the Medicaid law doesn't change, but for this state, for Kansas, some of the rules are being suspended. They are generally demonstration projects. They have to promote the Medicaid program's objectives, which aren't defined in the federal law other than to provide coverage and do good things. So that's a broad, permissive kind of statement. And then lastly, 1115 waivers are approved at the discretion of the Health and Human Services Secretary, and then usually operate through a negotiation between the state and CMS. So this has to be approved if it's going to move forward by the HHS Secretary, who's Kathleen Sebelius. A little bit about the timeline for this. Oh, a couple more things about 1115s. Oh, I had that in my slides too. It has to be budget neutral to the federal government. So it means that under the 1115, the Medicaid program in Kansas won't spend more federal money than it would have if the waiver was not approved. It doesn't have to save money necessarily, but it can't spend more. And it establishes a per-person cap on the federal outlay over the life of the waiver, which for a budget person is a technical way of saying the way that budget neutrality is measured or counted is at the per-person level. And there are a couple states that have a global cap, but that's a different question. So There was a new regulation that a regulation that was approved finally last spring that gave some additional guidance on the process for approving 1115 waivers. And so there's a little table at the beginning that talks about kind of dates along the way. I can answer more detailed questions about that if you have them, but the main idea was to give a clear direction to states on what the process is when a state wants to ask for this kind of waiver flexibility under 1115. And it created a requirement for public notice before the state submits a request and after the state's request has been submitted, before CMS can make a decision one way or the other about the waiver. And we can get more into the details of that. But here are the critical dates for this waiver. The state resubmitted their application to CMS on August the 6th. They received notice from CMS that their application was complete on August the 21st, and that triggers a 30-day public comment period that CMS runs that's going to stop on September the 20th. So there's a website on the CMS website, 1115 waiver, Josh probably knows what it is, but that you can type in comments that you might have about this proposal, and those go directly to CMS as they're considering it. The final part of this regulation that's really important is that CMS can't approve a waiver request any earlier than 60 days before the waivers, 60 days after the waiver was submitted. That means that CMS can't make a decision about this waiver until October the 5th. That's the 60th day. So there won't be any decision, there can't be any decision by CMS until after the first week of October. So that means there are some other key dates that move along, but that is a really important date that after October and sometime between October and the 1st of January, the CMS has got to get approval from CMS to have the plan move forward. A couple other key dates from the contract. On October the 12th, the MCOs have to show that 90% of their provider network is in place. And there was a legislative hearing yesterday that there was more discussion about what 90% meant and what in place meant, and we can talk more about that if you have questions, but the main idea is that the MCOs have to prove to the state and certify that they've got 90% of their network built for all the services they have to provide across the state by October the 12th. And then November 28th is, according to the schedule that the states published in their contract documents, is when the initial beneficiary assignment would occur. So the state will go through all of the enrolled Medicaid beneficiaries as of that date and assign them to one of the 3 MCOs and send out a packet saying, welcome to CanCare, you've been assigned to United Healthcare. And you've got 45 days to select another plan and how that's supposed to work. It won't say 45 days because that would be way before, it'll say something about the timeline. And then January 1 is when the contract actually starts and the MCOs are required to provide services. That's subject, of course, to CMS approving the waiver and CMS approving the contracts that the state has signed with the MCOs. And there's probably a little bit of a chicken and egg question of whether CMS can approve the contracts before they approve the waiver. There aren't a lot of examples of that I've seen, but both of those things have to happen before January 1st. And then the other date that I would add to this, based on the discussion yesterday, was that there's a go, no-go decision that the states has to make, whether they're going to hit the January 1 target date or not. And Secretary Sullivan said in the testimony he gave to the Legislative Budget Committee that was October the 19th. So on the 19th of October, if that's the timeline that is maintained, there'd be some decision about whether January 1 is going to be the go-live date or it'll be, I won't interpret what go, no-go means. I assume it means whether January 1 is the start date or it's something else. So those are important things to look at. So that's a little context. I assume we're taking questions at the end. This is the slide that would have what our website is, but it's khi.org that links you both to the news service and our research on this particular topic. Thank you.
I'm going to move quickly here so we can get this done. I will say my most important task is to get everyone out of the room by 11:45 so they can set for lunch. So, Joshua, that's a little warning for you. So if you do have questions, we'll have them both standing out in the hallway fielding questions while they're setting up for lunch for them. Joshua Deeker, JD, oversees the Kansas Health Consumer Coalition's member communications and social media and helps promote, review, and synthesize research in support of KHCC's advocacy priorities. Prior to joining KHCC, Joshua was co-founder and partner in mixed media, Topeka-based communications and campaign strategy firm. He consulted on issue advocacy and legislative initiatives across Kansas and Oklahoma, including the successful 2009 Vote Yes to Fix Our Streets campaign in Topeka, which, yes, they're still working on 3 years later. Before, if anyone's driven to Topeka, you know that. Before founding mixed media, Joshua worked in constituent services in the district office of Congresswoman Nancy Boyle. Through that work, he helped Kansans who were struggling with inadequate access to health care and developed a passion for identifying and addressing the shortcomings of the existing health care safety net. Joshua holds a BS in political science from Emporia State University and a JD from Washburn University School of Law.
Thank you. I always feel a little bit outmatched when I'm asked to speak with Scott here because his understanding of these policy issues is way out of my depth. But I will talk a little bit about our advocacy efforts with regard to the CanCare policy and what we can still do as advocates to impact the process and help make sure that it's an open and transparent process. KHCC is a statewide nonprofit organization whose mission is to advocate for affordable, accessible, and quality health care in Kansas. We've worked since the announcement of the governor's CanCare proposal to ensure that the Medicaid system is implemented in a transparent and accountable way. We have convened a coalition of advocates to work together on establishing a set of shared priorities, a shared message, and a coordinated effort to lobby the governor's office and the legislature for accountability and transparency. In March, we convened a panel of experts in managed care to address the public regarding how it has worked in other states and what pitfalls to watch for in developing a comprehensive managed care system in our own state. Since then, we've convened several community meetings around the state of Kansas regarding CanCare, and these events have played an important role in shaping the ongoing discussion regarding CanCare in the State House and throughout the public. We see accountability and transparency as applying primarily in 3 ways, and the first of those is in informed implementation. One way of ensuring informed implementation is through being open to consumer feedback. During this initial implementation process, this means taking information about the program, making information about the program available and accessible to the public, and it should include how it was developed, what the likely impacts are for beneficiaries, as well as for the state's budget, and the reasoning behind major decisions as they're made. It also means, once the public is armed with this information, creating a meaningful way for the public to weigh in on the policy as it's being developed and implemented. Under new federal transparency regulations, the state is required to hold public forums on CanCare to gather input. The state met those regulations in June by hosting 2 town hall-style meetings, one here in Wichita and one in Topeka. During those meetings, the state gave a presentation outlining how CanCare would operate and then opened the floor to allow attendees to ask questions and express their concerns. As you may recall from media coverage of those events, the public response was overwhelmingly skeptical. Under the same federal transparency regulations that require those public forums, the state also has to summarize the public's questions and concerns and respond to them specifically in its application to CMS. The state has done this to a point, but we find some of their responses lacking as far as really providing an opportunity for consumer feedback to have an impact on the process. One example of how their answers don't necessarily respond adequately to public concern, and there are a number of examples in the CMS waiver application. One question is asked, how exactly will the health homes work? The state's response is when different populations will gain access to health homes, but doesn't go into any detail at all about how the health homes actually operate, how they'll work. And we find throughout that application there are answers like that that just don't really hit at what the public's concern actually was. And our comments to CMS will reflect that we feel like consumer engagement is an important part of this process, and it's not, though they're working toward the appearance of consumer engagement by having public forums, by listing out these public concerns in their waiver application, they're still not actively engaging with consumers across the state. As advocates for transparency and accountability, we're absolutely glad that the state hosted these town halls, but there's just a lot of questions as to whether these 2 meetings are actually sufficient to inform the public about a reform as complex as CanCare, and we'd certainly like to see more follow-up on the issues that were raised in the public. It's also important to remember that consumer feedback is going to be an important part of the CanCare program, not just during this initial implementation phase, but also after it's up and running, after it's the Medicaid program for the state. That means that for consumers that are already beneficiaries, we need to make sure that they have access to information about the grievance process, about how to access it. The grievance process needs to be uniform, and it needs to be accessible. For those that aren't already beneficiaries, information about how to access the benefits, where to go to access the benefits, what benefits are available. This all needs to be made easily accessible to the public. Consumer engagement is an important part of this program, both now while it's being implemented and in the future after it's been implemented and when it's the program. And as advocates, it's important to remember that as policy decisions are made, we still have a lot of work to do to ensure that consumer feedback continues to play an important role. The next way of ensuring informed implementation is through stakeholder involvement and stakeholder engagement. And as advocates, we actually had some real successes in this area. The first of these successes was the appointment in March of a Consumer Advisory Council. This group is tasked with reviewing CanCare and making recommendations to the Governor's Office, and is composed of consumers. Its creation is a great step in the direction of meaningful stakeholder engagement. Similarly, the state convened 4 external stakeholder work groups to give input and advise the state on the continuing development and implementation process. These groups include members of the Advisory Council, as well as healthcare providers, representatives of the 3 managed care organizations, and consumer groups like KHCC, as well as members of the public. These groups were not envisioned as the original CanCare proposal, and so the fact that they exist at all is a testament to the efforts that we've all made together as advocates to try to create more openness and transparency in the process. But as I've mentioned before, simply setting up the appearance of transparency and openness, setting up the appearance of stakeholder engagement, doesn't necessarily mean that our work is done as advocates. For instance, we have found that it's sometimes difficult to see the issues that are being brought up in these organizations translating into actual policy action on the part of the state. So it's unclear how much of the advising that they are set up to do is actually making its way to decision makers and impacting the implementation of the program itself. A recent example of this was the development of print materials for Medicaid beneficiaries explaining the upcoming changes. The state developed a brochure, but rather than reaching out to advocates before designing and developing the brochure, they came to advocates in the work groups and said, this is our brochure, it's done, it's ready to go to print, what do you think? And as advocates, we had some real concerns, both with the content of the brochure, whether or not it was relevant and important and the kind of information that consumers need, as well as the accessibility of the brochure's language itself. When confronted with our concerns, the state's response was, unfortunately, we're on a very short time schedule. We have to get this to the printer. There just isn't time to make changes at this point. So it just illustrates, while we've set up these work groups, and as advocates, we're very happy that we have this opportunity to address our concerns with the state as CanCare is being implemented. There's still a lot of work to be done to try to make sure that the things that we are bringing up in these meetings, in these groups, are actually having an impact on the process. Additionally, despite the fact that the Advisory Council has been set up and these work groups have been set up, major policy decisions are also being made behind closed doors, and we're still really struggling to get in and have an impact there, which means we have a lot of work to do still. Recently, at one of the state's public educational forums about CanCare, it was revealed that Medicaid beneficiaries who currently have access to a case manager may have to change to a new case manager after the program becomes implemented on January 1st. Originally, consumers and consumer advocates were assured that those who have case management services currently will be able to keep their existing case manager. This decision was rolled out in a public forum, having never been brought up, to our knowledge, in any discussion in a public hearing or public meeting. So again, as advocates of transparency and accountability, though we've made great strides and we have some successes to point to, we still have a lot of work ahead of us in trying to get this process opened up more widely to ensure that stakeholder involvement is meaningful and robust. And so the third strategy for ensuring informed implementation is to pace the implementation appropriately. An analogy that is frequently heard around the State House is of a speeding train, used in reference to CanCare, saying that once the train has left the station, there's just very little that can be done to stop it. But as advocates, we feel like a program as big and as complex as CanCare shouldn't be thought of as one massive, unstoppable train. It should be started in small and manageable pieces that we can study and reform on the fly as we need to before we unveil it and release it for the entire population. Strategic pilot programs and strategic pilot programs that test the program on smaller groups of consumers to work out the bugs before implementing it for the entire population would be an excellent way of doing this. In a few ways, the state is using this approach. For instance, and a major success for the advocacy community, is the carve-out of the population with developmental disabilities. They will not be part of the CanCare program through the entire first year. Additionally, the state has proposed pilot programs to test alternatives to traditional Medicaid, as well as employment programs for people with disabilities. Testing these programs on smaller groups, smaller subsets of the population before broadening the scope to the entire state will allow the CanCare program to identify shortcomings and problems and make adjustments. As advocates, we'd like to see more of this, with staged implementation paced to allow the state to make changes to the program as needed to ensure that it will work for Kansas consumers before putting the entire Medicaid population into it. As with consumer and stakeholder engagement, the work of assuring accountability and transparency doesn't end once CanCare is up and running. Even when the program is fully implemented, ongoing policy and cost analysis information should be made available to advocates and the public at large so they can be reviewed and reformed as necessary. The second way to apply accountability and transparency to CanCare is through effective legislative oversight. This was a major focus of advocates throughout the 2012 legislative session, and you can expect it will be a major focus in 2013 as well. Also, despite the fact that we didn't get this legislation across the finish line in 2012, I still count this as a partial or an in-process success for advocates, and that's because both chambers, the House and the Senate, passed legislative oversight legislation. Additionally, the governor's office has said they support the legislation, they'll sign it when it gets there. So as advocates, we've done a really good job here. We have convinced the decision makers that this is an important part of the program. Unfortunately, and the reason we didn't get it moved through and completed in 2012 was political differences between the House and the Senate. I don't know how many of you followed the last legislative session closely, but it was one of the most contentious in recent history. And the House and the Senate drew battle lines and had a very difficult time getting anything done between the two chambers. And what held up the legislative oversight legislation was which chamber would get to select the chair of the Legislative Oversight Committee during the first year. The committee's chair will alternate between the two chambers every year, and they just couldn't decide whether the House or the Senate should get to pick the chair first. We're confident we're going to get it done in 2013. Because it's not an election year, it should be far less contentious. And again, it's an idea that has very broad support in both chambers of the legislature as well as in the governor's office. That said, and as the recurring theme of this presentation, our work as advocates is not done. Until the legislation is actually passed, signed, and made law, we have a lot of work to do. And so this is another area where we all should be contacting our members of the legislature, reminding them that this is an important part of CanCare, and it's something the legislature can do to help make sure that it's implemented in a transparent and accountable way. We have a lot of opportunities to do that. You know, prior to the election, this should be part of every candidate forum that we attend. After the election, when we introduce ourselves to new members of the legislature, this is one of the things we should talk about. And when we reintroduce ourselves to existing members, this is one of the things we should bring up. This is a major legislative priority, and it's one I'm confident we will see success with when we enter the 2015 session. So finally, the third way to ensure transparency and accountability is through timely access to data and analysis. Data and analysis are key to ensuring an open and transparent system. All the public forums in the world won't help ensure CanCare works if the public doesn't have access to information about customer satisfaction, access to services, network adequacy, health outcomes, and cost savings. This is an important point that should be part of our discussion with CMS in upcoming CMS comments, as well as with members of the legislature and the governor's office. Currently, the state is projecting savings of $1.2 billion over the next 10 years through the implementation of CanCare. They're assuring improved health outcomes through better coordinated care and through improved access to more and better health services. The only way those claims can be evaluated, and more broadly, the only way the CanCare program as a whole can be evaluated by advocates and by the public, is if the state's data and analysis are made public for review. It's this kind of information that's essential to our ability as advocates to ensure that the system works for Kansans. So finally, knowing that accountability, I'm ready for the next slide. Knowing that accountability and transparency are essential in any Medicaid system, and knowing that those goals can be achieved through informed implementation, legislative oversight, and timely access to data and analysis, what should be our next steps and what are our goals as advocates? The first and the most pressing step, as Scott mentioned, is the public comment period for the CMS waiver comments. That public comment period is open until September 20th. Comments can be submitted online, and they can also be submitted in hard copy. It's very important that CMS understands the concerns that the advocacy community has about the CanCare program, because in their negotiations with the state, CMS is going to be positioned to ensure that some of the policy changes that are priorities for us get made. Additionally, as I mentioned before, keeping in touch with our legislators about legislative oversight, a very important step that we as advocates need to be taking to ensure that the program is implemented both initially and as an ongoing program in a transparent and accountable way. And then finally, and maybe most importantly, just stay engaged. KHCC, OHK, numerous advocacy organizations all have regular newsletters with updates about what's happening in the legislature about CanCare, what's happening with CMS, what's happening in the governor's office, and there are changes and there's new information all the time. And as advocates, it's important that we stay engaged, that we stay informed, and that we work together to make sure that the state implements the policy in a way that's transparent and accountable. So finally, for the last slide, I just included some resources. Links for information about CanCare itself can be found at the official state CanCare website. KHCC, my organization, has put together a consumer action toolkit that's got a lot of information. It includes our first CMS waiver comments from the first round of the waiver, talking points, just a ton of information about advocacy around CanCare. And then finally, I've also included the link to the CMS waiver comments website. I think everyone has a copy of or has access to the presentation, right? Okay, and great. So it's on the website. So the resources and the information here hopefully will help you stay in tune with the advocacy efforts that we are engaging in, and also help inform your own advocacy efforts. So that's all I have.
Thanks, Joshua. First announcement, if you're looking for CU credits, please make sure you sign up outside at the table. We have about 5 minutes for questions, if anybody has any questions. And we also have one last door prize. I know we're going to do that after we take a question or two. Does anybody have any questions arising from these presentations? Yes.
For Scott, talk a little bit more about 90% of the providers. What kind of discussion did you hear about what that means? Signed up by a certain date?
There was one comment yesterday that said it was 90% built, contracted, and credentialed. So that would imply that not only there are several levels of certification the state has accepted or suggested. One are letters of intent, so a provider would sign a letter saying, at some point in the future, I will agree to sign up with one of the companies based on some criteria. A contract means you've actually entered a contractual relationship, you're going to accept Medicaid patients and whatever the MCOs are going to pay. And credentialing means you have to go through the MCO process of being enrolled in their system so you can bill and get paid and things like that. So that was the first time I had heard the 90% meant contracted and credentialed by October the 12th. And that's good for providers to think about. The other thing is what 90% of what?
Yeah, that's
And
fine.
I needed to go back and look at what the 90%, there are some access standards, provider adequacy standards in the contract. I don't have a clear idea of what that number would be. There's some geographic standards and timeliness of appointment standards that need to be met, but that's the 90% reference point. And that's about as much as I've gleaned from the contract at this point.
The one prescient final question maybe, Kevin, or do we have maybe time for one more than that?
Well, I guess just on that, I mean, at least one of the dental vendors don't even have an approved contract yet. And today's September 14th. And we're talking 90% of whatever on October 12th, so when it comes to at least the one dental vendor, whatever this 90% is, it would seem pretty unlikely to me. So what happens if they don't get to 90% by October 12th?
Well, I think that would contribute to the go, no-go decision that the state needs to make. I don't think there are any contract penalties for the MCOs if they don't meet those targets. They're
They have targets, but it's in order for the state to make an overall decision on final implementation then, more than anything?
The targets are designed to give a stepwise approach to implementation so that you would have there's a clear point when there's an expectation of what the network would look like on this day. If that isn't met, that is a factor that the state's going to have to use in their decision of going live, or what additional efforts need to be made, or what other decisions need to be prioritized to make sure that things continue along the pace at January 1. It's the great part about not working for the state anymore. I gave you a pretty good answer.
I mean,
but I don't know what-
in the scheme of CanCare, one dental vendor not being at 90% by October 12th is pretty insignificant, assuming the other ones are all moving forward.
When all three companies have to have networks built statewide, I don't know that one can be behind the other two when they're going to each get a third of the population. So they're at a competitive disadvantage then as the members look at where they got assigned. So all the incentives are aligned to keep everybody moving at relatively the same pace.
Any more questions?
One
Yes, Joe.
Just one more thing. I think I was told, Joshua, that you could go online, and if you didn't want to make your own comment, you could like other people's comments. So
Absolutely. You can like other people's comments, you can make comments on other people's comments. It operates a lot like a social network.
So if it's kind of intimidating to write your own, I thought that was a nice idea to be able to.
Absolutely. I'm glad you brought that up.